Diagnostic HbA1c cutoff for diabetes mellitus, ADA, equals 6.5%. Fasting plasma glucose, mLG/DL, that defines diabetes on 2 occasions, greater than 126 mg per DL. 2-hour plasma glucose in 75-gram OGTT diagnostic of diabetes, milligrams decimals, equal 200 milligrams decimals. Random glucose with classic symptoms diagnostic threshold, milligrams per deciliter, equals 200 milligrams per deciliter. First-line oral agent for newly diagnosed type 2 DM with BMI greater than 25 kilograms per meter squared. Metformin. Long-acting insulin analog with ultra-long greater than 42 hours flat profile, insulin degludec. Initial IV insulin infusion rate in diabetic ketoacidosis, units per kilogram per hour. 0.1 unit per kilogram per hour, no bolus. Electrolyte that must be equal 3.3 MEq per liter before starting insulin in DKA, potassium. Drug class that can trigger euglycemic ketoacidosis in diabetics? SGLT2 inhibitors. GLP-1 receptor agonist with proven CV mortality benefit in T2DM, semaglutide or liraglutide. Sulfonylurea safest in CKD stage 4, predominantly hepatic clearance, glipizide. DPP-4 inhibitor that needs no dose adjustment even in ESRD, linagliptin. Charcot foot in diabetes results from loss of proprioceptive sensation, neuropathy. Honeymoon phase in type 1 DM refers to temporary partial remission. DOC to treat painful diabetic neuropathy, first-line oral, duloxetine or pregabalin. Serum osmolality threshold greater than MOSM kilograms in hyperosmolar hyperglycemic state, 320 MOSM kilograms. Plasma ketone predominant in DKA pathogenesis, hydroxybutyrate. DKA resolved when anion gap less than N and bicarbonate equals 15 equal liters. Break time 400 milliseconds, 12 equal liters. Screening microalbumin, cutoff mLg per gram of creatinine in diabetics, 30 nLg per gram. Preferred antihypertensive to slow diabetic nephropathy, ACE inhibitor or ARB. Target LDL-C for diabetics with ASCVD milligrams per decipil, less than 55 milligrams per decipil. Triiodothyronine, T3, is produced mainly by peripheral conversion of thyroxine, T4. High total T4 but normal free T4 plus normal TSH suggests excess, thyroxine binding globulin. Painless hyperthyroidism with low radioiodine uptake, likely entity, subacute de Quervain, thyroiditis has pain. Painless equals silent postpartum thyroiditis. Best initial drug for thyroid storm to block hormone synthesis and conversion? Propylthiouracil. Radioiodine therapy contraindication absolute pregnancy. Antibody most specific for Graves' disease activity. TSH receptor stimulating antibody, TRAB. Thyroid malignancy associated with RET proto-oncogene point mutation, medullary carcinoma. Serum calcitonin used to monitor which thyroid cancer post-surgery? Medullary carcinoma. Most common cause of primary hypothyroidism worldwide. Autoimmune Hashimoto thyroiditis. HER2 cells and thyroid FNAC are typical of thyroiditis. Hashimoto. Aprosity rate 120%, replacement dose of levothyroxine, micrograms kilograms day in healthy adult, is equal to 1.6 micrograms kilograms day. Pregnancy increases levothyroxine requirement by a roughly 30%. 30%. Anti-thyroid drug preferred in first trimester pregnancy, propylthiouracil. Serum calcium normal but PTH high. Diagnosis: secondary hyperparathyroidism. Stones, bones, groans refer to symptoms of primary hyperparathyroidism, hyper-Ca squared. Cinecalcit mechanism of action: calcimimetic activating Ca sensing receptor. 25OH vitamin D deficiency cutoff, Nga milliliter. Nuts, 20, -0.12. Hypocalcemia plus hyperphosphatemia with low PTH. Diagnosis: hypoparathyroidism. Chvostek's sign elicits facial spasm due to low calcium. Most common cause of Addison disease in India: autoimmune adrenalitis, previously TB. Screening test for adrenal insufficiency, gold standard: ACTH, concentropin stimulation test. First-line steroid replacement regimen in Addison: hydrocortisone, 15 to 25 milligrams per day, plus or minus fludrocortisone. Low-dose overnight dexamethasone suppression test screens for Cushing syndrome. Cushing disease is excess ACTH from what? Pituitary adenoma. Ectopic ACTH most commonly from which lung cancer? Small cell carcinoma. Ketoconazole treats Cushing by inhibiting this enzyme, 1720-lyase, 11-beta-hydroxylase steroidogenesis. Plasma-free metanephrines, best initial screen for tumor, pheochromocytoma. Preoperative blockade sequence in pheochromocytoma: alpha blocker first, then beta blocker. Drug of choice for hypertensive crisis in pheo: IV phentolamine or nitroprusside. Speak: MEN2B mucosal neuromas, marfanoid habitus gene mutation codon. RET 918. Hyperaldosteronism screening ratio, PAC-PRA, positive when greater 20 nanograms DLL per nanograms milliliter hour. Spironolactone side effect limiting in males, gynecomastia. Bone disease, Rugger-Jersey spine implies secondary XX. Hyperparathyroidism of CKD. BXA T-score equals -2.5, defines osteoporosis, equals -2.5. Sachs uses which BMD site? Femoral neck. First-line anti-resorptive for postmenopausal osteoporosis, alendronate. Anabolic osteoporosis drug stimulating PTH receptor intermittently, teriparatide. Speak: prosody rate 120%, Paget disease acute pain doc. Break time 400 milliseconds. IV zoledronic acid. Prosody. Pituitary macroadenoma, mass effect, best first investigation. MRI brain with contrast. Prolactinoma doc medical, cabergoline. Acromegaly iochemical cure, IGF-1 normal plus glucose suppressed GH is neg engrams per milliliter, 400 milliliters. Most common hormone deficiency post-pituitary surgery. GH deficiency. Sheehan syndrome results from infarction of another pituitary postpartum. Polyuria, polydipsia, urine osm less 300, desmopressin raises osm. Diagnosis: central diabetes insipidus. Nephrogenic DI, first-line oral drug, thiazide diuretic. CADH, asymptomatic hyponatremia, initial management, fluid restriction. Prosody rate 120%, rapid correction of chronic hyponatremia risks. Osmotic demyelination, central pontine. Drug causing SIADH among antiepileptics, carbamazepine. Speak: prosody rate 120%, MODY3 gene mutation, HNF1 alpha, prosody. Metformin contraindicated when eGFR equals less than milliliters per minute squared quantity, volume times 400 milliseconds. Insulin secretagogue that can be used in renal failure, short half-life. Repaglinide. Thiazolidinudone contraindicated NYHA class, heart failure, class 3-4. GLP-1RA common GI adverse effect leading to discontinuation, nausea, vomiting. Latent autoimmune diabetes in adults, LADA antibody positive, GAD65. Insulin storage temperature, unopened vials, 2 to 8 degrees Fahrenheit. Hypoglycemia unawareness treated by raising target glucose for weeks, 2 to 3 weeks. Dawn phenomenon managed by shifting NPH insulin to the PM, late evening bedtime. Whipple triad defines insulinoma-related hypoglycemia. MEN1 triad tumors, parathyroid, pancreas, pituitary. Most common functional pituitary microadenoma, prolectinoma. Craniopharyngioma arises from remnants of Rathke pouch. GH suppression test uses oral glucose. IGF-1 half-life allows it to be a screening test for acromegaly. Most sensitive early marker of diabetic nephropathy, microalbuminuria. UKPDS showed tight BP control reduced microvascular risk by 37%. Non-ketotic hyperglycinemia enzyme defect, glycine cleavage system. Amiodarone can cause both hypo and thyroidism, hyper. High TSH plus high T4 suggests pituitary, TSH secreting adenoma. Reverse T3 elevated in syndrome, euthyroid sick. Drug that decreases peripheral conversion T4-T3 besides PTU, propranolol. Hypothyroid patient plus adrenal insufficiency, treat first. Adrenal hydrocortisone. Adrenal incidentaloma, greater than 4 centimeters or hormonally active, next step, adrenalectomy. 11-beta hydroxylase deficiency causes hypotension and androgen excess, virilizing. Congenital adrenal hyperplasia screened by elevated in newborn, 17-hydroxyprogesterone. Osmotic demyelination risk highest with chronic NA ml moles, liter, 120. Calcitonin gene-related peptide monoclonal is used in endocrine-linked migraine, name 1, erinumab. Serum fructosamine reflects glycemic control over past weeks, 2 to 3 weeks. Postpartum thyroiditis phases follow hypo, then recovery, euthyroid. Incretin effect lost in T2DM due to reduced secretion, break time 400 milliseconds.